तुमको माल की बहुत सी तलब ने अल्लाह से गाफिल कर दिया, यहाँ तक कि तुम कब्र तक जा पहुंचे। हाँ तुमको जल्द मालूम हो जाएगा, फिर हाँ तुमको जल्द मालूम हो जाएगा। अगर तुम जानते यकीनी तौर पर तो माल की मोहब्बत ना रखते। अब तो तुम जरूर दोज़ख को देखोगे, फिर तुम उसको इस तरह देखोगे तो तुमको पुख्ता यकीन हो जाएगा। फिर उस रोज तुमसे शुक्र नियामत की पुरसिश होगी। सदकुल्लाहुल अजीम, सूरा नंबर 102। जज़ाकल्लाह खैर।
Thank you, Nadeem. That was very soul searching. Right, Dr. Rameez, it's all yours. I'd like to all the participants to shut their videos as well, please. Rameez, you can carry on.
Assalamu alaikum everyone. I'm Dr. Rameez from Mangalore. I'm a pediatric dentist running a clinical practice in Mangalore. My today's webinar topic is on pulpectomy in primary. So I'll try with the best of my ability to explain the major difference between the primary and permanent tooth treatment, and as well as the basic clinical protocol or steps that we have to take to achieve the best possible results in terms of prognosis. So as a clinician, when we are confronted with a necrotic or infected pulp, usually we have two options in mind. That is, either we can go with an extraction of the tooth followed by a space maintenance, or we can save the tooth by doing a pulpectomy on that particular tooth. As a clinician, we should always try and save the tooth for various reasons that I'll be discussing in the upcoming slides. Now, what is pulpectomy? Pulpectomy is, as the name suggests, pulpectomy. That is surgical removal of infected coronal and radicular pulp, and then obturating it with a medicated resorbable material so that the tooth is safe until it exfoliates naturally. Now, this is the question that everyone asks us: is it really worth saving primary tooth? In 1933, Capnick also put out this question. The major reason for the negative attitude that we have towards saving the primary teeth is the fear of damaging the underlying permanent tooth. Another reason is the difficulty in negotiating, cleaning, and obturating the primary tooth canals, which is why most of the clinicians prefer removing rather than treating the tooth. Now, we as a dentist should be very convinced that we should save the tooth, and so that we can also convince the parents to do the same. Now, what is the reason? First reason, as we all know, it helps in mastication. Now, this is the first step in digestion, which is required for the nutrition, which in turn is very important for the normal growth and development of the child. Another reason is it guides the permanent tooth to a proper position in the oral cavity. It acts as a natural space maintainer. If at all we extract the tooth prematurely, what happens is there is a loss of arch length, which will lead to ectopic eruption of the premolar. In case of extraction of primary molar before the eruption of permanent first molar, what happens is there will be a major dipping of the permanent molar, which will also lead to the loss of arch length. Another reason is its importance in speech development. So certain words like which is called as dental consonants like ta, da, sa, these are all requires help of a tooth. So primary tooth is very important in case of developing a speech also. Now, this is the reason which I prefer as a periodontist, most convincingly that why should we save the primary tooth. Now, if you see, we might have seen so many kids with such anesthetic like looking teeth. Most of the kids, even though they are active at home, they don't socialize outside, they don't speak outside. It's majorly because they have that shyness, they don't have that confidence in them because their teeth doesn't look good. So as a periodontist or as a dentist, we are supposed to change that. Now, on the left side, what you see is a 5-year-old, and on the right side, he was a 3-year-old. Now, in this, the changes in the attitude that was seen was immense. Like parents were so happy that they told they personally came and told that sir, that's my child was never talking outside, but now is even ready to act in the play in school. So there is a lot of confidence, boost in confidence, as well as development of positive attitude in the children. Another reason is the fear of extraction. Now, we all know, even we as an adult are scared of extraction. So when we say that we are not going to extract, but we are going to save your tooth, most of the fear and even the behavioral changes is seen in the child. So this is one of the reasons, these are the various reasons that we have to, as much as possible, try and save the primary tooth. Now coming to the difference between the primary and permanent tooth. Now, from the occlusally to the root, when we go through, we see a lot of anatomical differences. Specifically, major differences, the size of the tooth. That is, in case of primary, it is very small compared to the permanent tooth. And in the coronal part, enamel dentin, so it's much thinner compared to the permanent counterpart. Now, what it does is it allows the pulp to be much closer to the occlusal surface. Now, this is clinically relevant because it can lead to mechanical perforation of pulp exposure, or it can also lead to the carious pulp exposure easily. Especially the mesial pulp horn is much closer to the occlusal surface in case of primary tooth. And in the furcation region, we see a lot of accessory canals. Now, this is the reason we don't see periapical radiolucency, but we see a furcation radiolucency or interradicular radiolucency in case of primary tooth. And the roots are very slender; they are thin mesiodistally. And even the challenging part is it's continuously resorbing, so we don't have a fixed apical foramen as such when we compare it to the permanent tooth. Now, these are the major differences that we have between primary and permanent tooth. Now, another reason difference is because as by the age of 3.5 years, the root is completion is done in case of primary molar teeth, and the root starts resorbing. As soon as the root resorption starts, there is a lot of secondary dentin deposition inside the canal system. Now, because of this, there is a continuous change in the canal system. There is formation of lot of fins, there are lateral branches and accessory canals as the root resorption progresses. So the root canal system is not constant in case of primary tooth. It keeps changing as the age advances. Now, coming to the indication, when do we actually opt for pulpectomy? Now, irreversible pulpitis, when there is a clinical signs of irreversible pulpitis or necrotic pulp, we go ahead with that is when there is a continuous pain, when there is swelling, we opt for a pulpectomy. Now, radiograph is recommended to see a lot of details. That is, for example, in the first radiograph, if you see, clinically there are patient has continuous pain, but radiographically there is no much change. Like there is a good amount of root length, there is good amount of bone structure, and no much inflammatory changes that is seen in radiograph. In this case, we go by the clinical presentation and do the root canal treatment. And in the second X-ray, if you see, there is changes in the furcation region. There is a widening of a periodontal ligament near the furcation area, and there is also involvement of pulp. Now, in case of this is a case of disinfection. Now, in such cases, what we have to see is we have to take a radiograph and see if it is worth saving it. If there is good amount of root structure and if the bone resorption is not that much and the mobility is also not that severe, wherein we have to advocate extraction, then it's always better to go and save the primary molar in this case. Now coming to the contraindications, then we shouldn't touch the tooth and go and do a pulpectomy. Now, when there is a extensive root resorption wherein there is no root to be saved, then it is in the first radiograph, if you see, it is not indicated. And when the lesion is so huge that it is affecting the upcoming underlying permanent tooth, in that case also it is better to go for an extraction. And when there is extensive internal or external resorption, the pulpectomy is contraindicated. And in case of primary tooth, the major perforation that you see is near the furcation ridge. That is the third radiograph here you see. In such cases also, the prognosis is very poor. It is better to extract the tooth. And when you cannot fill the tooth properly, when you cannot give a good post-operation restoration, then it's always better not to do the, in this case here in the anterior tooth, if you see it's very grossly decayed, so it's better to get it extracted rather than doing a pulpectomy. Now coming to the clinical diagnostic tips, apart from radiographs, what you have to do is we have to see whether the pain is spontaneous or provoked. If it is spontaneous, if there is a night pain, then only that means the tooth is chronically inflamed or it is necrotic. Now, in this case, what we have to remember is kids are not good historians. We should always, because as we ask kids, they cannot localize the pain, they cannot give a good history. So we should always take a support of parents in such case. Another important thing that in kids we have to very much remember is never tap the tooth with the handle of the mirror. This is as good for adults also, but in especially in children we should never tap, because the moment you tap and there is a pain, it will change their behavior. So the easier way is to use your thumb or fingertip to apply some amount of pressure and see if and never ask the patient whether it hurts or not. What you have to do is you have to see their body language, you have to see their eyes, the signs they show whether there is pain or not, and also check the counterlateral counterpart, the other side of the arch, so to see whether the reaction is genuine or not. Then coming to the pulp sensibility test. Now we have a lot of heat test, cold test. In case of then electrical test. In case of kids, it is advised not to do such sensibility test, because what happens is it can make the child lose confidence in you and change his behavior. So the pulp sensibility test is not that accurate in children as we do it for adults. Now coming to the objectives of pulpectomy, why do we offer pulpectomy? That is, we have to maintain the tooth free of infection, then biomechanically cleanse and obturate the root canal with the resorbable material, and to promote the physiological root resorption in primary tooth, and so that the primary tooth acts like a space maintainer for the erupting permanent tooth. Now, what are the clinical steps that we have to follow to do a pulpectomy? First, we anesthetize, then we isolate the tooth, then go ahead with access opening, then working length determination, then we debride the canal followed by obturation. Now the local anesthesia, one thing, the first thing what we have to do is apply topical anesthesia, so we can at least avoid that a pinch that is caused by the pricking of the needle, so that the patient is more comfortable. And one of the technique that we can use is counter irritation. That is, while giving in a maxillary region or the mandibular region, what we can do is we can stretch the cheeks so that the concentration or the because of the pressure, the child doesn't feel the pinch of the needle. It's called as counter irritation, and it acts with the gateway theory of pain pathway theory. Then coming to the distraction. Now, this is a good technique. Either you can keep your mobile phone or a tab in front of the patient eyes and keep him distracted. Or if you don't have that, you can have a monologue with the patient. Keep talking to him so that he is continuously distracted while giving a local anesthesia, so he doesn't have any pain. And the most important thing is delivery rate. We are not supposed to just inject the LA into the child. What we have to do is we have to slowly regulate our not less than the delivery should not take less than a minute. We should take as as slowly as possible to give a anesthesia to the child, and we should remove that fear of injecting the local anesthesia, because many people think that giving an anesthesia can disrupt the child behavior. That is a wrong concept. Actually, if we give an anesthesia, good anesthesia, and if the entire procedure becomes painless, then that child will never go to another dentist. He will always be thankful to you that you have done a painless treatment. But if you fear giving an anesthesia, and if you don't do it, the entire procedure becomes painful, and the child will have a negative attitude towards the dentistry. Now, whether to give a nerve block or infiltration. In case of maxilla, because it's a porous structure, we have cancellous bone. So infiltration near the root is good enough to anesthetize the tooth. But in case of lower, that is mandibular tooth, we have something called as rule of 10, in which the tooth number. Now, tooth number means from incisor to the molar. We give a tooth number as 1, 2, that is 1 for incisors, 2 for laterals, 3 for canines, till 5 for the second molars. We designate the tooth number and then add the age of the child. Now, if this sum is equal to 10 or less, then the infiltration works. If it is not, if it is more than, the number is more than 10, then the infiltration is not sufficient. You have to go for a block. Now, this is just a vague thing given by Mathewson, and it really works well when, especially when giving a block in case of lower inferior alveolar nerve. We usually have a fear of going deep, or it might hurt more. So infiltration is much less painful when compared to the block. So we can always try this technique given by Mathewson. Now, coming to the isolation. Isolation is very important part. Most of the time, even myself, we neglect this important part, because thinking that might consume a lot of time. But once you put the rubber dam, then the entire procedure becomes easier and faster. And it helps in protection from aspiration, especially when we use these small files when the child is jumping around, wherein there is a chance of slippage of instruments. So it actually protects from aspiration, and you get a very clear working area. There is no saliva, no bleeding, and even your soft tissues are protected. And for now, especially this time wherein we are very concerned about aerosols, it also reduces the aerosol in the environment. The most important thing that we have to use rubber dam is for this reason. Now, this child was 6-year-old. I had done a lot of treatment in him. Still, he doesn't. Even after so many behavior modification, he was still uncooperative. So I thought I'll just apply this technique and see if it helps in behavior modification. And what I saw is, after the rubber dam was applied, for the entire half an hour, this child was motionless. He even slept during the treatment. So it really affects the behavior. Yeah, sometimes we have that fear when the child is really uncooperative. We really don't think about putting a rubber dam, and we just want to finish it off and send. But this helps in calming the patient down, because what in research they say is it gives an externalizing effect that the child feels like work is not done inside his mouth, whereas it's done outside the mouth. That psychological feeling is what makes them calm. Now, once the isolation is done, everything is set, what we have to do is we have to remove first all the caries that is there. Then do the as we do the access opening, we get a dip. So once we get a dip, because the pulp chamber is big, usually in primary tooth we get a dip, and then we move the burr on a outward in a sweeping fashion in the outward direction. Now, in my clinical practice, this endo Z burr has been a life-saving burr, because it is a non-cutting. It cuts only on the lateral aspect. So, especially in wherein the child is very uncooperative and it's difficult to, there are chances your burr can hit the furcation area, and furcation area is very thin. So this has really helped me in giving a good access opening, and access opening is a very important step in case of root canal, because if you don't have a good access opening and good visibility, then your entire upcoming BMP or any other procedure becomes, it doesn't give 100%. We cannot clean as good as we want to. Now here I want to tell one more thing, that is I'll be talking more on molars, because the anterior tooth is straightforward. It is a single canal. Most of the time it is single rooted and a wide canal, and there is no much thing to be explained in that. It's just access opening, you clean the tooth and you just fill it. So there's no much thing to talk about, because of less difficult in anterior teeth. So I'll be concentrating more and explaining it in terms of molar, that posterior tooth. The same technique is applied for the anterior tooth as well. Now coming to the canal system that is there in the primary tooth. In maxillary primary molars, we have canals ranging from 2 to 5 canals, in which most of the time, that is in 75%, we see MB2 canals in first molar, and 85 to 95% we see in the second molar. Now this what it shows is MB2 is not an accessory. It is a main, and we have to search for the MB2 canal as much as possible until we don't find it. And this picture depicts, thanks to Dr. Nadeem sir, he gave his photo to me. Thanks sir. This if you see this MB2 here, it is very close to the MB canal, and most of the time this is present. We have to look out for MB2 canals. And in case of first primary maxillary molar, we see a distal canal and the palatal canal fused in almost 1/3 of the cases. Now coming to the primary mandibular molars, usually there are 3 canals, wherein almost in 75% we see 2 canals in the mesial, that is MB and ML. And only in 25% of cases we see 2 canals, as we see in another photo here on the right side. We have D1 and D2, but most of the time in 75% of the cases it can be a fused root in the lower molars. And the root canal system in primary molar is characterized by ribbon-shaped root morphology. It is that is the reason it is very difficult to negotiate the canals in case of primary molars. Now this is a very interesting. This is basically a classification of root canal morphology. But what I want to highlight here is, if you see, this is a 7/4. That is a third quadrant D. If you see here, the mesially there is 2 orifices, and it ends in a 1 apical apical opening. But as the resorption happens, what happens is there will be a 2 orifices and 2 apical openings. In same way, if you see here, there is a single orifice splitting into 2 apical openings. but as the resorption progresses, it becomes one orifice with the one opening. So what I want to say is the primary molars is continuously changing. The root morphology continuously changes as the time progresses. So we cannot treat it like how we treat permanent molars. Now coming to the working line determination, we can take an X-ray with the files inside, and whatever measurement we see, for example, if we have the files at the apex here, we should detect 1.5 to 2 millimeter from that, which is a safe working length for in a primary tooth. Or a better technique was given by Garshagoda in 1987. It is a brilliant technique. What he has told is the underlying permanent tooth bud. Now that can direct us into getting a proper working length. Now, if in this case, if you draw a horizontal line on the occlusal surface of the developing tooth bud, in this case, in the first picture, if you see, the file can be kept at the apex of the tooth. But whereas in case where the permanent tooth bud has erupted, when we draw a horizontal line, now this area becomes your apical stop. Now we are not supposed to file beyond this region to avoid over obturation or over instrumentation. Now coming to the apex locator, it is in case of permanent tooth, they have shown very high accuracy rates, but in case of primary, that's not the same case. In primary, it is shown that it's not accurate, and it's better we don't rely on apex locator. If at all we get a reading, it is always we have to keep the files 2 mm short of the reading what is shown in apex locator. Now, how do we do the canal debridement? Shorter files has to be used. We can either use K or H files, and in case of thinner canal, that is on the mesial aspect of molars, usually up to 25 or 30 file size is good enough. Or in case of distally, we can go up to 35 number. Now, this is a personal preference of each clinician, what they use. I personally like using H file. Yes, they are aggressive, but if used judiciously, we can use it to our advantage. And selective filing has to be done. Selective filing means we are not supposed to file the percussion area of the tooth, but we have to concentrate filing on the lateral side. So while filing, we shouldn't apply pressure on the percussion area because it can cause perforation. And unnecessary filing, unnecessary widening of the canal should be avoided because the roots are thin and it can cause perforations. Now, use of broach, yes, it's an old technique, but sometimes because in case of primary tooth, it's unlike the permanent counterpart, wherein the pulp tissue is more fibrous. Here it is more cellular and it's very sticky too. It doesn't come out easily. So sometimes after all the cleaning and shaping is done, we can take a two size lesser broach and just insert and see if any pulp remnants comes out. Rather than shaping the canal, we can avoid shaping the canal in this case and just concentrate on pulling out the pulp tissue. Now coming to the Rotary, now this has become a trend now because it's much efficient in cleaning, and it's even cost effective, and the studies have shown that the obturation quality is improved. This is basically the reason is there is flaring of uh, uh, canals we see in case of rotary systems. Now, rotary systems, you can use a lot of the system that we use in permanent tooth. The only thing what we have to keep in mind is we have to limit ourselves to bare minimum preparation. We are not supposed to widen the canals like have how we do in the permanent tooth, 6%, 8%. This is not required, because as minimum as possible, our main concern is to remove the pulp out and then put in the obturating material. We are not concentrating much on the shaping aspect, but we are concentrating more on the cleaning aspect of the root canal system. Now here I have put only the pro table because that's what I do general practice here. So this is what is available to me. So what I do is I mostly use this SX5 and up to S1 or S2. So the bare minimum preparation that we can do, and it gives a good result. The obturation comes out really good when we use root. And specifically coming to kilo files, now these are specifically designed files for pediatric Rotary. The speciality of these files are, this is short files, around 16 mm of length we have, and the working length of the file is only 12 mm. So it is because in children the mouth opening is less. This acts, it really helps in the reaching the tooth, especially in the molar regions. And we have a variety in this. It's a single file system, wherein the red one is used for the thinner canals, the blue one is used for the medium canals, and the black one is used for the anterior tooth, wherein the canals are large. So coming to the irrigation, this is the most important part of pulpectomy, because we don't shape the tooth as much as we do it in the permanent tooth. So we rely more on irrigation to remove the pulp remnants, the necrotic remnants out of the tooth. So the ideal requisite of irrigating solution should be, it should be broad antimicrobial. It should be efficient against anaerobic as well as facultative microorganisms. It should dissolve the necrotic pulp, which is very important point that to be noted. It should inactivate the endotoxin. It should remove the formation of smear layer that is formed, and it should be non-toxic and non-caustic also. Now, what are the materials we have? We have a lot of irrigating solutions in market, but most commonly used is sodium hypochlorite, which the percentage ranges from 1% to 5.25%. But in case of children, we usually avoid the higher concentration. Most of the studies, most of the clinicians prefer 1% sodium hypochlorite solution to irrigate. This irrigation should be followed by a copious irrigation of that is so the normal saline. Now, hypochlorite, many pediatric dentists around the world don't prefer sodium hypochlorite for a reason that it is very toxic. If injected into the tissues, it can cause a very strong inflammatory reaction. So that's why, to be on a safer side, many prefer chlorhexidine solutions. Now, chlorhexidine has also shown a good results when used as an irrigating solution. But the problem with chlorhexidine is, as we see in hypochlorite, hypochlorite helps in dissolving the pulp tissue. Whereas chlorhexidine doesn't do that. And chlorhexidine is also, it doesn't act on a gram-negative microorganisms. So when you compare it with hypochlorite, chlorhexidine is not that up to the mark, but many prefer just to avoid the dangerous part that we see in hypochlorite, that is the inflammation that can cause because of injecting into the tissues. What a sequence that we have to follow in irrigating solution is, we follow with hypochlorite. What I do in my practice is, I fill the chamber, or I'll just put a 2 or 3 drops of hypochlorite in the pulp chamber. Then along with that, I do the cleaning of the canal, which helps in moistening the canal also, and it helps in removing of the pulp also. And this should be followed by copious irrigation of saline. Saline should be not be used in small quantity. It should be used in copious irrigation, so that we can flush out all the hypochlorite out of the root canal system, as well as we remove all the pulp remnants. EDTA can be followed to clean the remove the smear layer. Now, one thing what we have to keep in mind is when we are using hypochlorite, never combine it with chlorhexidine. It can cause a reactionary product like parachloronin, which is known to have a carcinogenic effect. So we should be careful that we don't combine these two solutions. Final irrigation should be done with a normal saline, and then we have to go ahead with obturation. Now we dry the canal with paper pins. Never air blow just to dry, and but use a paper point and dry the canal nicely. Now we have different materials that we use for obturations, and there are different techniques also. And whether gutta perca is indicated or contraindicated, I'll be talking it in slides. Now, what should be the ideal pulpectomy obturate? Now, anytime we select obturant, we should remember this permanent molar, or permanent premolar. Now, anything we insert, it should be resorbable, because if it goes beyond the apex, it should resorb. It shouldn't hinder the eruption of the permanent tooth. It should be easy to insert, as well as it should be easy to remove in case of failure of any treatment. And it should be radiopaque. Radiopacity in the sense we should know whether the obturation is done properly or no. And it should be antimicrobial, because we don't shape the canal much, so we have to rely more on the obturating material to do the part of it should be antimicrobial, should take care of the infection. Now coming to the various root filling material, we have zinc. Major classification is we have zinc oxide eugenol, we have calcium hydroxide with the iodoform, we have calcium hydroxide, we have iodoform base, and we have combination of all. Now all of this I won't be talking, because most of the materials we don't use. Now this is a new obturating material that is being researched on, that is 3% nano chitosan. Basically, it's a mineral that is found in crustaceans, and they have shown that it has a good prognosis, not as compared to the materials that we have in the market, but they are trying to improvise on that. Now, to the material that I'll be concentrating on is zinc oxide eugenol. It's the most commonly used obturating material. The only drawback is, as I told, easy insertion and easy removal. It is not easy to remove the zinc oxide eugenol once it sets inside the canal. Another reason is it resorbs slowly compared to that of the primary root. So there are chances that the remnants can stay within the tissue. Another important material is Vitapex. This is a pre-mixed. It comes in a pre-mixed plastic syringes. This is a calcium hydroxide with iodoform, and even the Metapex. Now, Metapex and Vitapex is almost very similar, but in Metapex we have more. It leans more towards the iodoform based, and Vitapex contains more amount of calcium hydroxide. In both the materials, the major disadvantage that we see is the resorption rate is much faster. Sometimes I had a case recently wherein I had obturated 2 years ago, and when they came for recall, there was no material inside the canal. So that is one of the disadvantages we have. But apart from that, it is considered almost an ideal root canal filling. Then endoflask. Endoflask is a mixture of all these things, and that also has a good prognosis. Now, the basic question, the basic confusion that we have, which material to use for obturation. This review article makes it easy for us, wherein what they concluded is zinc oxide eugenol with the, because the resorption rate is very slower, it is preferable in the tooth which is not going to exfoliate soon. That is the tooth which has to stay in the oral cavity for a very long period, then we can always opt for zinc oxide eugenol. It has very high success rate till date. And when the tooth is going to exfoliate soon, then calcium hydroxide based is preferable, because anyways it resolves faster also, and it is a good material overall, with a overall good success rate. Now, obturating technique, I'll be why I'm starting with this calcium hydroxide is now the thing with the new practitioners like me, we want very quick obturations. So this gives a very quick obturation, that is, we just need to inject into the canal. That I have a video on this, which I'll be playing it in the end. It's a very simple technique. The only problem, as I told, is it resolves faster, and there are chances that you can over obturate if you really apply pressure and inject into the canal. So that has to be avoided. But this is a very easy way of obturating the primary tooth. Now this video will be being now coming to the zinc oxide eugenol, how can we obturate that? Now in incremental filling technique, what we do is we first mix the zinc oxide eugenol into a luting kind of consistency, then either use a reamer or a gutta perca and coat the canal. Once the coating is done, then you take a very thick mix of ZOE and place it near the orifice, and use the cotton pellet to force it into the canal. So when you apply the pressure, the ZOE will slowly seep in towards the apical region. You can also use a plugger to push the set the plugger 1 or 2 millimeter short of apex, then push it so that we can push the material as much as possible, and again use a pellet to force it into the canal. Now another technique, this which we learned in our PG days, is use of amalgam carrier. Now we have a variety of modification, depends on practitioner's preference. Now we do a lot of we try a lot of things where we can make it easy. What we concentrate is the end result. End result should be good. So this amalgam carrier, it helped me to carry the material towards the orifices. So it's easy to take the material, thick material of ZOE, and just push it into the canal. So with the plunging action, most of the material gets in, and then we can it's the same incremental filling technique. Then other thing that we can use for filling ZOE is inhibited. Now these are very thin flexible metal tips. In this cases, the consistency should be very less, and the problem with injection technique is it can cause over obturation. Lentilo spiral can be used. Lentilo spiral, for example, if you have prepared the canal to 30-35 H5s, then two size smaller lentilo spiral you can use. So you have to use it around like 6-7 times to just fill the canal, and it is shown that though it is good in obturating, it can over obturate the canal most of the time, and a lot of voids are also seen in using lentilo spirals. Then endodontic pressure syringe also can be used. Paper point, as I told, coating the canal, it can be used, or insulin syringe or tubercular syringe. Now all these things, one thing what we have to remember is how we put ZOE into the syringes. Now mixing it outside and putting it inside the syringe is very messy. That's the reason many people don't avoid using syringe techniques. But another technique which I follow is, if I have to inject, I directly add the powder inside the tube and the eugenol and mix it within the tube, so it doesn't become that messy and it's easy to use it. Now, how should be the obturation in the end? Now, ideally, the obturation should be flush at the apex. What happens if there is an under obturation? So this is Nadim sir's another X-ray wherein he had under obturated. Again, he removed the filling and took a pain to again fill the canals. Now, yes, it is a good thing to have a good obturation, but in case of primary teeth, most of the researchers have shown that under obturation doesn't there is no much significant difference in success rate between under obturation and flush obturation. The reason behind it is the most important thing is what we remove out of the tooth. That is as we have read in Grossman, that is what comes out of the tooth is more important than what goes in. So here, main thing is canal debridement should be good, and if it is an under-obturated tooth, you don't have to worry as such. The success rate won't change as much, but overfill should be avoided at all costs. Now, overfill, what it can do in case of calcium hydroxide, because it resorbs very faster, we don't have to worry much as such, but it can cause inflammatory reaction, it can cause pain. In case of ZOE, what happens is because it sets into a hard mass, it can deflect the permanent tooth, but the direction of the eruption of the permanent tooth can be altered. So that has to be kept in mind because ZO, zinc oxide eugenol resorbs much slower. And there has been cases also wherein after the tooth was exfoliated, some amount of zinc oxide eugenol was still remaining in the tissues. So that has to be kept in mind that the over obturation should not be, it should be avoided. Now, how can we, now how can we avoid over obturation is, as I told, sticking on to the techniques, that is following Garcia-Godoy technique of working length is very good. We can avoid over obturation, or keep create a apical stop 2 mm away from the apex. Now this stop will not allow the obturating material to go flow beyond it. And if you are in doubt, always take an X-ray and see if you have obturated well or no, rather than just pushing the material inside the canal. Now, is Gattaperka indicated in primary or no? Gattaperka is contraindicated. I recently had a case wherein I think I had posted in the group also, wherein surprisingly there was a Gattaperka in the primary tooth, and there was lot of there was abscess and patient had swelling because the that Gattaperka acted as a foreign body, and that Gattaperka doesn't resolve. So we should at all cost avoid Gattaperka, except in one case wherein we don't have the permanent premolar tooth. Now in such cases, what happens is the primary tooth is going to stay for a very long period. Now primary tooth as such won't be there for your entire lifetime, because what happens is one of the reason of resorption is permanent tooth, but apart from that, even the masticatory load that falls on the tooth also acts, and even the inflammatory reaction that takes place because of the excessive load can restart the resorption process in the primary tooth, and in long term it can exfoliate. But for the long term success in case of primary tooth wherein the permanent tooth is missing, in such cases we can always go ahead with Gattaperka obturation, not in any other case. And once the obturation is done, we can follow it by a GIC or composite. Then followed by a SSC. Now, recently we had a question also, why go for a stainless steel crown, rather settle with just GIC or composite. But what happens is, because the pulp chamber is wide, when we do the access opening, the remaining enamel and dentin that is left is very thin. So even though we give a good composite for GIC restoration, there are high chances that the tooth can fracture. So the best option that we have after pulpotomy or pulpectomy, that's because the access opening is already a wide tooth. It's always better to go for uh, 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 stainless steel crowns. Or in such case, now we have zircon and variety of crowns also. Now the recalls. Recalls, we can recall every 3 to 6 months. In every recall, the thing what we have to see is whether the tooth is functioning, if there is any pain or infection, if it is firmly attached to the oral cavity, and if it's undergoing a physiological resorption or pathological resorption. If it is physiological resorption, good, the tooth is again going to stay for some more period of time. And radiographically, we should always check if there is any furcation or periradicular lesions. Now, before concluding my webinar, I would like to show this uh, research article. It was very interesting. If you remember my slide on contraindication. Now, we had contraindication wherein we shouldn't treat focally involved excessive resolved root and very severely infected furcation pathologies. It's indicated for extraction. But recently a study was done wherein 24 months of follow-up was seen, wherein these tooth which were indicated for extraction were saved. Now this material what they used was something called as 3-mixtratin. It's basically a antibiotic mixture with the statins mixed with it, and they have seen it gives a good result. It in a permanent tooth, we call it as LSTR, that is lesion sterilization and tissue regeneration techniques. And the reason I put this is, as a dentist, we should put a very strong effort in saving every single primary tooth. That concept that primary tooth is just going to fall off, it's not important. At first we should believe, then it is way, easier to convince the public at last. If we as dentists are not convinced that anyways this is going to fall off, chalo leave it, then we cannot convince the parents or public at large to save this tooth. So coming to the conclusion, pulpectomies are very highly successful. It is almost 80 to 100% of the time we have seen the pulpectomies are success, and there is no better space maintainer than a primary tooth. Now, this is the best space maintainer, natural space maintainer that we have. So, this every primary tooth is worth saving, and when we keep a rational fundamental in case selection and operative techniques, pediatric endodontics remains a major benefit to child's health and well-being. Thank you.
Thank you, Dr. Rameez. You were supposed to show us a video, if I'm not wrong.
Yes, sorry.
If you don't mind, please.
Is it visible, sir?
You need to stop sharing the screen and then go to the video, if possible. I mean, you can share your screen, but just go and open the video in a, in a little window, and then you can play it.
Ah, okay, sir. Good.
Yeah, that's it. Brilliant. Are you going to talk us through this?
Yes, I have already recorded, sir. Is it audible?
I can't hear what you can just talk us through it if it's possible, please.
Okay. So what we do here is we adjust our rubber stop 2 to 3 millimeter short of apex, and make sure it is not snugly fit in the canal. And as we inject, we slowly withdraw the syringe out until the excess is seen in the orifices. Once this is done, we take a wet cotton pledget and we compress it against the canal. Now what it does is it will reduce the voids and compress the canal lateral materials into the canals. Was
Fantastic.
it clear?
Thank you. Thank you. Anything more you'd like to add, Dr. Rameez?
No, sir. This is it, sir.
Brilliant. Can you stop sharing the screen now, please, so we can go on with the next part of the session? Wonderful. And I'm going to get Dr. Nadeem Ahmed. Oh, I think he's left. So I'm going to bring in the panelist. We've got Dr. Sabah Sheikh, who is our panelist, and she has completed a Bachelor of Dental Sciences from Yanapoya Dental College, Masters in Pediatric Dentistry from CODS Davangere, and a gold medalist from the Rajiv Gandhi University of Health Sciences. Dr. Sheikh, I'm just going to unmute you. Welcome. Welcome, Dr. Sheikh.
Thank you, sir.
Thank you very much. Yeah, we can hear you loud and clear. But thank you very much, Dr. Rameez, for your wonderful, interactive and educative. I'm hoping it becomes interactive now, because I want more questions on this. This is one of my favorite topics as well. I'll pass it over to Nadeem to put forward the questions. If there are any questions missed, I will, interrupt and I will put it across as well to the panelists. But thank you. I think I'll stop my video and let you guys do the talking. Thank you.
Assalamu alaikum, Dr. Sabah Sheikh. Welcome aboard. Fabulous presentation, Dr. Rameez. Mashallah. Excellent. It's always pleasant to hear, someone speaking on pediatric dentistry and pulpectomies, missing those cases from past 2 months, lockdown period. Trust me, I'm missing all this. Okay. I think I have a question from Salman Siddiq. Dr. Mubarak, I'll go ahead with this question. I missed one question, I think because due to my internet connectivity. Let the panels take the question. By that time, you can go ahead with the question which I lost just before Salman Siddiq's.
So you're going to start with...
yeah, that would be great, actually. That would be in the flow. Can you just check the question?
I will start off with the first question was from Dr. Asim Basha. Okay. Is intranasal spray helpful in achieving local anesthesia in children? Both of them can talk.
Intranasal spray can, you mean in case of sedation, sir, or anesthesia?
It says local anesthesia. Is there any intranasal local?
No, intranasally it won't help. Say any topical anesthesia will just anesthetize the tissue. Whereas infiltration or the block only can help in giving a good numbness to the tooth. And good anesthesia is very important for behavior management as such.
Fantastic. Dr. Sheikh, would you like to add something to that?
So the local anesthesia cannot be given intranasally, but there is intranasal midazolam that is given for the sedation procedures, but not for local anesthesia.
Can you come back again on that, Dr. Sheikh? Can you come back again on that, your answer?
The local anesthesia, so it has to be given locally where you're going to do the procedure. But an intranasal spray will not bring about the local anesthesia. But there's something called as intranasal midazolam. Intranasal midazolam sprays are given during the process of sedation procedures.
Okay. So midazolam you're talking about, right? Yeah, fine, alhamdulillah. But is it given? Is it advocated? Have you come across any cases where you have?
I have not given, sir, but there are people who do that, and I've seen some articles where they do that intranasal midazolam.
In case of in SDM, sir, when I was doing PG, before general anesthesia, they usually prefer this just to sedate the child so that they can go ahead with intravenous. I've seen cases where they give it intranasal.
As in
but that is for sedation.
As in does it reduce the anxiety of the child before going?
Yes, it reduces, it calms down the child. Then it's easier. He'll cooperate for the intravenous.
Okay. Fabulous. Shall we go to the next question? So in case of...
Was that the only question I lost, or are there
no,
many
there's
other
one more.
questions?
There's
Yeah,
one
okay.
more. There's one more. This is from Dr. Manan, Syed Abdul Manan. In case of furcation involvement, how do you go about it in a primary tooth?
In case of, sir? What?
If there is a furcation involvement,
Yeah, okay.
how do you go about treating that or doing pulpectomy in those kind of teeth?
Sir, if you can, as I showed it in the last slide, MTA or such thing can be used. But most of the time when there is furcation involvement, the prognosis is very poor. So it's better to go with extraction and then with the space maintenance.
And Dr. Sheikh, how about you?
It's a complete contraindication for pulpectomy in primary teeth. If there is a furcation involvement, you have to go for extraction followed by space maintenance.
Fabulous. I'm going to let Nadeem. I think Nadeem, these are the two questions you missed. Can you just tell me who was the next one you were going to talk about? Question.
I think the third question would be from Salman Siddiq. This is what you see on your screen, right?
And what is the question?
Point of needle insertion.
Yeah, that's correct. So
Yeah,
I'll mute myself. You guys carry on. Yeah,
and that would be great. Thanks, Dr. Mubarak. Dr. Salman Siddiq asks, the landmarks for inferior alveolar nerve block, is it the same in pediatrics and adults, or does it differ?
Sir. In case of pediatrics, what we do is we take a reference of the occlusal table in the lower molars. So what we do is, if the child is below 5 years, then the syringe is directed below the occlusal table. Around 6 years of age, it is kept at par occlusal table. And in adults, it's same as how we give in adults. Like we palpate for the notch and dissect the a nail and give.
Right. Dr. Sabha, do you really need a block in pediatrics? Why not just a simple infiltration?
No, so for maxillary teeth, infiltration is enough because of the porous bone. But when it comes to mandibular teeth, as Dr. Rameez told about the rule of 10, that is one way which he has put forward. But what I have experienced is, especially when there is a highly inflamed pulp, the infiltration in mandibular teeth doesn't work. You have to go for block. This is what is my experience, because in maxillary teeth it works. In highly inflamed teeth, it will not work if you just give an infiltration.
If it is an highly inflamed, even the blocks will not work. It is something like a hot tooth there, you know.
Yes.
Yeah, that's also there.
Yeah. So eventually, we are giving intrapulpal there, just to get the complete anesthesia effect. I would really prefer to give infiltrations in pediatrics, because blocks, the landmarks are not really great when the kid is shaking his head. You might, tend to, miss your marks. Right, Dr. Rameez? Just correct me if I'm wrong.
Most of the time, sir, as you told, even if we miss the landmark, in the end, the injecting anywhere close to the nerves will give a good block in case of children. But most important thing is anesthesia should be perfect. If just to avoid another prick or a pinch that child will feel, and if we hesitate in giving a block, then if the entire procedure becomes painful, then the child won't cooperate.
Exactly. And one more, the biggest thing I dread in pediatrics after a block is post-op complications of the kid coming back with severe chewing of his lip, a big ulcer, and
yes.
Trust me, that is the biggest headache to treat more than the tooth itself. Do you agree, Dr. Sabha?
Yes, sir, I agree. But that's what, when you give the block, you have to inform the parents that it will be numb for 4 hours. You have to take care of it. But thing is, as Rameez told, why I give block for mandibular teeth is, if you give just infiltration and you think it is numb and you start the procedure and the patient feels pain, then they become uncooperative again. So it is better you anesthetize them completely, make sure it is working, and then you start.
Agree. The next question is from Dr. Nadeem. He asks, the Rotary files, what we use in permanent teeth, can we use that in primary teeth? Or is there any advantages or disadvantages on it?
So, in the end, see, the main reason we use rotary is not to shape the canal as such. It's just to extirpate the pulp. So, using rotary that we use for adults, it doesn't matter, but the taper shouldn't be much. Like, for example, using a 6% taper can perforate your focusation area. So, it should be minimal taper, and the advantage of nickel titanium, as we know, it can, flex, and because of tortuous canal system that we have in primary tooth, it is more efficient in doing. But we can, yes, we can use, but not like in case of pro taper. Now we have S1, S2, F1, F2. You don't have to go up to F1, F2. uh, Bare minimum
What's your take on the length of the files?
length of the file, sir, it should be as short as possible. Now, in case of keto files, what they have done is they have kept it at around 17 mm. Basically, accessibility helps.
Yeah, I think Dr. Nadeem was trying to hint on that. Dr. Sabha, your take on this?
About the rotary files in pediatric patients, the primary teeth, what I feel is we can use rotary files as an adjunct to our hand files in primary teeth, especially because in primary teeth we're not going to shape the canal. Shaping the canal is not a primary purpose. Our main purpose is to remove the pulp and remove the necrotic tissue. The one thing what happens is when we use the rotary files, we are reducing the time which we're giving. We are reducing the time which we're working on the tooth, and thus we are reducing the time the irrigants are acting on the tooth. But in primary teeth, the main way by which we are removing the debridement is done is by the irrigants which I use, the sodium hypochlorite. So what we can do is we have to, like what I do is, we have to use the primary, the hand filing until 30, 35. Later, if you want to get a nice obturation, for that purpose, you can use the rotary file. Otherwise, I think we should concentrate more on hand filing and using and proper debridement rather than shaping the primary teeth.
So basically, it's the clinician's choice about hand filing and rotary files. See,
Yes.
the bottom line for success of any treatment is your chemomechanical preparation. That's you use your hand files or rotary files. And I think just to add a point, the reason why adult rotary files I would not use is because the length of the files are anything between 21, 25, 28, and 31. And the pediatric files are all 16 mm. So the working length of the file itself is 12 mm. So they are more shorter and stiffer. It does not separate. You have better control over the file. That is what I feel. Just to add a point on that. The next question is from Dr. Abid. This is to Dr. Rameez. Please explain how rubber dam can be time consuming. You did explain in one of the slides stating that rubber dam can be time consuming. Would you please justify your statement here?
No, rubber dam is not time consuming. So I've mentioned there as it can help in, I don't think so. One minute, sir. I'll just go back to the slides.
Yeah, because he precisely asks how RD can be time consuming. Probably he is asking this, you would have mentioned in your talk or in one of the slides.
Protection from, no sir, I have not mentioned it as because in the hands of a trained individual, it's not time consuming. If I'm putting a rubber dam for the first time, yes, it will take extra time of like 5-10 minutes. But once the rubber dam is placed, it will really help because the child also calms down. He won't jump around, so your work becomes much easier. It won't consume much time. I feel it will help in reducing the working time. I don't know if I've told it in the talk, sir. But I've not mentioned in the slides.
It is always a race against time when you have a pediatric patient
Yes.
sitting on the chair, Forget the rubber dam. I would like to, get this patient in and out as early as possible. What's your take, Dr. Sabha?
Yes, sure. Correct. But one thing I want to add is when we are using rubber dam in children, it's always better, like it goes with adults also. You have to check if he's a mouth breather or not. If the child, especially they'll have enlarged tonsils, we have to check that. If they're not mouth breather, if they're nasal breathers, and anytime rubber dam is very helpful. And if the patient is cooperative, you can use it. That is one of the best things you can use.
Yeah, true. Working under rubber dam is always safe, and you can prevent, plenty of mishaps. Okay, the next question is from Dr. Asim. Any of the panel member or the speaker can take this. What is your opinion on Dakin's solution for irrigation? That is sodium bicarbonate and sodium hypochlorite.
Not that sure. Not going through his.
Honestly speaking, this was used during World War era, World War II, Dakin's solution. So I don't know anybody is using this now. I'm going to unmute Dr. Asim if he's got any supporting evidence or literature on this. Yeah, Dr. Asim.
Hello, Nadeem. Assalamu alaikum, Nadeem.
Walaikum
Very
salam.
nice presentation, Dr. Rameez, mashallah. No, actually, the thing was here what we say is that the pH is 11 to 13, and it is a strong proteolytic and has got a very good oxidative properties. Dankin solutions. So there are a lot of literature regarding this using in deciduous teeth, but still it's not popular in India. Or is it because we don't get it commercially, or you have to prepare it?
I have to go back and check, sir. I have not come across this irrigated solution.
It would be great any of the, if the speaker and the panel member could get back on the Dakin solution on GDP. That would be great. Yeah. Dr. Asim, can we get back on this once the
Can I add something about Dakin? It was used predominantly for wound dressings and wound cleanings.
Yes.
It's an antiseptic. It's an antiseptic. It has got some properties of dissolution of organic material, but because of the other additives in it, I don't think it is predominantly. It wasn't that popularly used for endodontics. This is not for pediatric dentistry, but because it's a weak hypochlorite, it's got about I think 0.4, 0.5%.
0.5%.
Yeah, 0.5%. So I'm not sure if you have supporting literature, Dr. Basha, you can post it on GDP with regards to this, and then I think we probably might have a nice.
I'll do that.
If it's being used on pediatric tooth, it would be nice to discuss this as well, because as far as I know, it used to be used for cleaning wounds, if I'm not wrong.
Yes.
Right.
Sorry, I'll let you all carry on.
I think that was most widely used during the World War II era, if I'm not wrong, Dr. Mubarak.
It was used to clean wounds, and it was used later on after that as well as a disinfectant for the floors and other things, but that's a different story.
Right. Yeah. Fine. The next question is from Dr. Iftikhar. He asks if there is an erupting permanent tooth and there is active resorption which is happening, and you happen to treat that pediatric deciduous tooth, and how do you educate use of hypochlorite, and how do you manage that without going out periapically?
You don't do lot of copious irrigations with the hypochlorite. One thing is we have to keep the hypochlorite strength less as possible. Like in case of adults, we go up to 5.25, which they consider as gold standard. But in case of pediatric, less is better. Like 1%, 2.5% is good enough. And we are not supposed to copiously irrigate the area. We dripping kind of irrigation would be fine. In such cases, I don't think so. It can harm the. If you go over instrumentation beyond the apex can cause harm. But for that, we are anyways checking the working length, and all the preparation are 2 millimeters short of the apex. So we are keeping that safety margin of 2 millimeters, so it won't harm the permanent tooth. That is the main purpose of pulpectomy, so that we don't harm the permanent tooth.
Dr. Subha, you want to add anything on this?
So one thing, the concentration as recommended by APD is 1%. And what I do is, like, if there is an active resorption, use minimum amount of sodium hypochlorite for disinfection. And then what I use is triple antibiotic paste that is used for, I put the medicament and leave it for about a week. That will bring about more of disinfection rather than using this hypochlorite and damaging the permanent teeth.
I think the tap and dap itself is a big topic of discussion, and it has its own merits and demerits. And I think next question would be, regarding the same by Dr. Asim. He asks, how promising is SLTR in deciduous teeth? That is lesions, sterilization, and tissue repair. Yeah. So what's your take on this?
last slide which I had put, sir.
Yeah.
It was very promising result they have shown. The concept behind it is, if you sterilize the region, if there is no if the tissue is clean, then the body will heal by itself. So in case of permanent tooth, they have tried in apexogenesis. They have shown promising results in case of apexogenesis, but in case of primary tooth, that is the study which I showed you was it showed very promising results.
But do we really need all those antibiotics in that tooth?
Antibiotics, yes, sir. That is one of the drawbacks about the resistant factors, development of resistant bacteria is a problem, and that is an emerging problem also all around the globe. So I don't know if they justify that.
Yeah, Dr. Sabha, how often do you do these procedures at your practice?
Sir, I use this antibiotic mixture whenever there is an active infection, when there is a proper periapical abscess, when there is a draining pus. I don't go for systemic antibiotics. In any root canal, unless there's a space infection, I don't go for systemic antibiotic. And when there is a necrotic pulp, when there's a draining fistula, when there is a periapical abscess, I use triple antibiotic as an intracanal medicament for about 1 week to 10 days, and then I go for obturation.
What's your favorite combo? Yeah,
I use metronidazole.
Triple antibiotic phase. Which combination do you prefer?
Minocycline, ciprofloxacin, and metronidazole. 1:1, all three.
Everything 1:1:1, right? Right.
Yes.
And do you freshly prepare that, or can you prepare that and keep it for some time?
I prepare it. I prepare a small amount and keep it. Like one tablet, 1:1:1 ratio. 1 tablet. I prepare it and keep. And then whenever required, I mix it freshly and then use it. I prepare the powder and keep it.
Okay, can I interrupt you? Dr. Sheikh, you said you use it as a dressing, isn't it? Between
Yes.
the appointments. This was my earlier suggestion as well. With regards to using these triple antibiotic, I mean, I think Rameez just said the development of resistance. I don't see any justification on a tooth where there's no blood supply for the use of these antibiotics pastes. You could use, as I mentioned, as an intra-appointment intracanal medication, calcium hydroxide. It does the same job. It changes the environment. It makes it alkaline, reduces the bacterial load, and then you get back in after 2 weeks, flush everything out, and then obturate. You know, it works equally, in fact, sometimes better than the TAP and the DAP. But this is my opinion. But I'm sure you as pediatric dentists, know better for what's good for the children. Yeah. So because scientifically, the calcium hydroxide does the job. It does the same job.
I think this has always been under controversy. LSTR, the DAP and TAP and calcium hydroxide non-setting. But still, most of the pediatric dentists, they swear by TAPs, and and the endodontists, they swear by the non-setting calcium hydroxide. And I think there's always a sense of agree to disagree here.
There's always a controversy between pediatric dentists and endodontists.
It is an interesting debate. The reason I'm saying is, if you look at the various studies on calcium hydroxide, I mean, don't get me wrong, it's been used since late 19th century and into the 20th century, and it works on one simple principle, similar to how it is used in your casts of. I'm sorry, I'm deviating from the topic, but I'd like to make a point across that it causes an environmental change. Most of the bacteria which thrive in the canals, be it pediatric or endodontic, is predominantly acid production, or who thrive in the acidic environment. Calcium hydroxide completely brings the environment down to alkaline, making it, suffocating these bacteria. And that's what it does, because the use of antibiotics, of course, antibacterial properties is still there, but then, you still have that little element of exposing the child or the person to, stronger antibacterials, which is not required. But that's my opinion. Again, I put my hand up, and I'm sorry I deviated a little bit from the topic, but I'll let you all proceed. Thank you.
Fine, fine. Appreciate your inputs, Dr. Mubarak. Our next question is from Dr. Asim. He asks, any systemic conditions complicating pulpectomies?
Yes, sir. If, for example, in leukemia or any systemic problems like any endocarditis, wherein the infection can lead to systemic problem. Where there we have to take we have to outweigh whether saving of primary growth is more important or life. So if you cannot reduce the infection, and if that infection is going to harm the child, in such cases it is better to get rid of the foods, especially in case of leukemia and endocarditis.
Leukemia, what exactly are you talking about, Dr. Rameez?
No,
How
what
can it
they say
complicate a
is
pulpectomy procedure in
because
leukemia?
the infection fighting capacity of the child is very low. So in such cases wherein child cannot his immunity is already low, and we are trying something deciduous, we are trying to save, and if his body doesn't repair the tissue, in the sense if the bacterial load doesn't come down, then it's going to harm the child in a major way. So in that way, when you you have to outweigh the benefit against the loss.
Right. Any add-ons, Dr. Sabha?
In bleeding disorders, it is contraindicated, and also children suffering from rheumatic fever, because it can lead to endocarditis. That is why it is contraindicated. That is whatever.
Okay. The next question is, but just coming back to the previous question, bleeding disorders to pulpectomies, can you just correlate two things? I'm not able to correlate those two things here.
Sir, like if you go theoretically, according to the books, they have mentioned the bleeding disorders as a contraindication, like hemophilia and all that. And personally, I had not experienced with any patients, but recently, I think before this lockdown, one of my colleagues had a case, and in that open dressing was given for a patient, a 5-year-old patient, and the patient was bleeding from the tooth like continuously for 2 days. And they had to admit to the hospital, and then they had to give intracanal. The surgeon had to come and give intracanal adrenaline and all that. So after that, I think yes, it is a contraindication. And later, the parents revealed that the father had a bleeding disorder when he was a child. So, so I feel it is we have to be a little careful when anyone has a bleeding disorder.
I think never ignore any systemic condition, and I think prior taking consent from the physician is always better to start any treatment, particularly in systemic cases. Yeah. The next question is from Dr. Muhammad Abu Bakr. He asks, how do you manage weeping canals in primary teeth, and what ICM would you advise?
Sir, as Ali sir recommended, I prefer water-soluble calcium hydroxide. Now, what we obturate is usually it's a oil-based material like Vitapex and Metapex. But in case of intracanal medicament, I usually go for a water-soluble ones, which will disperse very quickly and help in reducing the infection.
Dr. Sabha?
Yes, sir, I agree. When you're using as an intracanal medicament, you can go with the saline and then use a water-based vehicle for calcium hydroxide.
Okay. What about Metapex itself, Dr. Rameez? Metapex itself is calcium hydroxide and hydroform, and that itself is an ICM.
Yes, sir. So actually, the thing is, when you have different rates of like the hydroxyl ion that is released. In case of water soluble ones, it is much faster. So see, when we inject Metapex, yes, it will act as a medicament, but the release of hydroxyl ions is very slower compared to that of water soluble ones. So what we can do is we can reduce the maximum number of bacterial contamination with the water soluble, keep it for like 5 to 7 days, then remove the material and go for a Metapex, which is an obturation material for the membrane.
Right. The next question is from Dr. Nadeem. He asks, are sedatives an answer to hyperactive kids, anxious children before the dental treatment? Can we calm them with any kind of anxiolytics or any kind of these drugs?
There are for example, now when we talk about these nitrous oxide sedations and all, the only thing is we can use it in an anxious patient. We can't use it in an uncooperative patient. Like uncooperative patient, the moment they remove the nasal hood, he will be hyperactive again. Apart from that, there are medications, but I would personally prefer it to be given by a pediatrician or them rather than we suggesting it, because if anything goes wrong, it is dangerous. That's what I personally feel. Even in case of general anesthesia, I feel we leave it up to the general anesthetist to explain all the pros and cons of everything, and we do the localized part. So that is my take on it, but you might have a better answer for that.
Honestly speaking, I have never given any kind of these medications, and I dread to use this in kids, because kids itself are quite dreadful when they come to you. And adding all this, that might the movie might get more intense actually. Okay.
So actually, in the pediatric groups, like I have many other groups also. There are people who use this. I don't remember the tonic name, but
it's Phenergan. It is Phenergan.
Yes, they gave it so that it calms it. But I don't know how safe it is. I've never used it, sir.
Doctors, actually, what happens? They give promethazine. Phenergan is promethazine, and it's a good sedative, that keeps the kid a little calm. But default, you pump in a liter of promethazine also, the kid is going to jump on the chair the moment he sees those instruments. And I did use once way long back, and I swear that I'm never going to use that back again in my clinic. Dr. Sabha, your take on this?
Sir, I have used, actually, I'll tell you, my father-in-law is a pediatrician and my brother-in-law is an anesthetist. So I have a good experience with all this, because I know, like, they have told me what not to do. So in a way, I have used pedicloryl, I have used Phenergan. Phenergan, both of these, they don't calm the child. They actually make the child sleepy.
Yeah.
But one product which calms the child is the oral midazolam. Oral midazolam is very effective. Many pediatricians are also using it. I think, like I have done a lot of, I've read a lot about it. Oral midazolam is comparatively much safer compared to this pedicloryl. Yeah. But only thing with that is, if you're using it, you have to keep the oxygen cylinder in you should know how to administer oxygen. Because the only disadvantage, the drawback is with that, it can cause hypoventilation. That is, the oxygen saturation might reduce. Minimum 95% oxygen saturation should be there. Oxygen saturation might reduce. If it happens, which is a very rare thing which can happen, but if it happens, you should always be ready to give oxygen. There should be an oxygen cylinder. You should have an oxygen mask, or the nasal prong should be there with you. If you have it, we can do it.
I think what you're advocating is we should have all this in a setup.
Yeah. We should have the setup. If we have, we can do it. Otherwise, better to be safe with the anesthetist on your side.
So I think you're a little on the safer side when you're practicing in your clinic, because you have a pediatrician, you have an anesthetist.
Yeah.
That's fantastic.
I do a few of GA cases so easily.
Oh wow, fantastic! That's great. Dr. Mubarak, you came in. You want to add something, or?
If you're looking at pediatric sedation, I think you shouldn't venture into it if you're not trained. That's my suggestion. If you're not trained, if you don't know what you're doing, don't even think about administering any drugs into a child. It's risky. So as Dr. Sheikh said, I think it's better you have the armamentarium and you have the support in the form of an anesthetist who knows how to revive the kid if something goes wrong. But other than that, I wouldn't venture into it. Sorry, I interrupted.
Actually, the Phenergan syrup is most widely used in India. I think Dr. Sabha would agree on this. Phenergan is most widely used.
Yes, Phenergan is readily available.
Yeah, readily available. It's widely used in those, cribby kids and who are always crying and cribbing for everything, and just to calm them out. And I think Dr. Mubarak would agree on this. He really loves pediatric cases.
I personally refer them. I don't treat pediatric because I'll be very honest. I mean, I put a rubber dam, I start to finish the case. But if I'm going to be treating children, I personally feel I refer them. Well, I've treated trauma cases, immature teeth. But those children, they knew what was being done to them. I have my neighboring, well, our sister practice is just next door. They have surgeons and anesthetists who sedate patients as well. I've not treated a child under sedation as yet, and I'd rather not, because I prefer a pediatric dentist to do the job.
Right. Going back to the next question, it's from Dr. Abu Bakr. He asks, Dr. Sabha, you want a break or something?
So give me a second, 1 second.
Yeah.
Yeah. Sorry, sir, I was slightly distracted. Yeah.
No problem. Take your time. I'll wait. Take your time. All set?
Yes, sir.
Yeah, fine. The next question is from Dr. Abu Bakr. He asks, what is the material of choice in a pediatric tooth where the permanent successor is missing?
In such cases, I would prefer gutta perca, sir.
What is the follow-up with gutta perca in these kind of cases? How many years?
See, we have to anyways recall the patient every 6 months. Now, a retained deciduous tooth doesn't mean that it's going to stay forever. There is going to be a resorption, but the resorption rate will be much slower. And cases have shown there are deciduous to be retained about 20 years. So, if at all there is a lot of resorption, you have to extract it as well as curate the socket also, because some amount of the GP might stay back, so you need to curate that part. But in long-term success, we can go for gutta perca and keep it under watch.
And Dr. Sabha, you have any follow-up cases?
Of this, sir?
Yeah, these kind of cases treated by you? Any follow-up cases? Because I had done once and I never followed actually, neither did the patient turn back, and I have no clue.
I have one patient, sir. I've done 6 months back. Hopefully they are related. So inshallah, hopefully they'll come back.
I need to track them. Yeah, you track them. 6 months, 1 year. I think that would be better.
Yes,
and
sir.
Yeah, there's not much cases. People who have done with the missing successor, and follow-up it's quite bleak. In fact, in the literature also. Okay, I think we are finished with the questions. I just have a query to both the esteemed doctors here. Why do general dentists fear pediatric cases in the clinic?
Sir, in my opinion, it's about management, sir. Like I've seen many parents coming and telling that dentist has given a gel to apply on the tooth so that the pain subsides, and wo gir jayega jaldi se. So the main reason is, one is behavior management, sir. Another thing is fear of complications. That's what I feel, because managing kids in adults, we see if at all, if there is any complications, we can still, justify ourselves. But if something goes wrong with the child, then you'll have to answer a lot of people. So I feel that's a personal fear that is stopping people from doing it. Apart from that, I don't see any wrong in treating, sir.
Yeah. Dr. Sabasi, I did have this kind of feeling in my initial days of my practice. The moment I used to see the kid, the first question I used to ask myself, why is this kid coming to my clinic? Why on earth am this dentist treating this patient? Trust me, I did have that fear. Neither you can say no, or neither you can say yes. Okay. The reason was, as Dr. Rameez, he's put everything accordingly in every place. The sense of fear of complications. Okay, but later on I realized complications are least in pediatrics compared to adults, because kids burst out crying, scream. So the part of the syncope itself is gone there. You don't have those people falling to syncope. Okay, they're letting out the fear. Dr. Sabha, your take on this? Do you agree what I'm saying, or you want to correct me?
No, sir, I agree with you completely, because my husband is an orthodontist and we practice together. And whenever any pedo patient comes in, he tells, Alhamdulillah, I married a pedodontist because he doesn't touch pedo patients. And the main fear is behavior management. And second thing is, some will not know the treatment, what to do for those, especially for deciduous teeth. I see many of them, they just suggest extraction. And I think it's better they refer to the pediatric dentist rather than doing those, just extracting the teeth and then causing all the malocclusions and other oral habit problems and all that.
Yeah, makes sense, makes sense. And I think any department missing in your family?
No, no, sir.
No, because good, yeah. You have an orthodontist.
Mashallah,
I
one of
think
the best.
orthodontist and pediatric dentists go well. Any hiccups by you, anything, your orthodontist
Yeah,
is always
yeah.
there to take care. Yeah, that's nice. That's nice.
Mashallah, Sabah, Dr. Sabah's entire family is a well-known doctor family in Mangalore, sir. Mashallah.
Good, yeah. So she is referring within the family to an orthodontist, to a she's a pediatrician, a pediatric dentist herself, in fact. Okay, that's nice. That's good to hear. Any more questions, doctors, in the group? Any more questions? Yeah, I think I'll put a last question, and we'll call it a day. How much of a solution would you suggest to inject in pediatric cases if you're giving a block?
So, see, I was reading about it. Around 5 syringes, up to 5 syringes. That is almost 150, 170 mg of lignocaine is safe. Like that is 7 mg per kg for a child. Maximum dose can be given. In
Okay,
case of blocks,
can you explain, since I'm very bad in mathematics, I don't understand mgs here. Let us talk mls here. If I have a 2 ml syringe with me,
yes,
one
we
is to
have around 1.8 ml in case of one barrel, sir. So if we say it is 2% of lignocaine, that will be 20 milligrams per ml. So in a syringe of 1.8 ml, we'll have around 36 milligrams of lignocaine. Now, if you go according to the maximum dose, that is 7 milligram per kg. If a child is around 20 kgs, so the maximum amount of lignocaine you can give is around 140 milligrams. Now in one syringe you have a milligram of 36 mg. That means you can safely give easily four full syringes. But it's not required. I'm just giving a theoretical explanation. But one syringe will do, sir. It blocks the. If a proper block is given, it will anesthetize.
right.
If I could just, sorry, if I could just say, I think if you look at lignospan or lidocaine 2%, since all the studies we've had, it's never caused any adverse reaction. There's only been one fatality of an adult patient, and that's because he was given 7 or 8 cartridges. And that's because the toxicity level of lidocaine increased. So I think if you look at it on an adult patient, as you mentioned, I mean, we use cartridges here, which is 1.8 ml or 2 ml cartridges, and the max we could go up to is 5 or 6 for an adult patient. So just half it, which means for a child, if you're looking at under 12, just half the dose, and that'll be three cartridges, and that'll probably be safe enough. Yeah. So I personally think lidocaine is extremely safe. It's brilliant. I think there have been a few studies now recently which has come through. I don't know. I think Dr. Gausia ma'am posted one with regards to use of articaine, and that can also be given safely. I mean, not for blocks, but for infiltrations.
Yeah.
Right. Sorry.
I think we are done with all the questions. Yeah, I think, yeah, I'll just check once again. Have I missed anything? No, I haven't missed. Okay, fine. Thanks, Dr. Rameez, Dr. Zaba, Dr. Mubarak. The dice is all yours. Yeah, I'm done with all the questions. Thank you.
Well, thank you very much, Dr. Sabah, for spending your valuable time clarifying our doubts, and Nadeem for hosting or being the moderator. Thank you, Dr. Rameez, and we're going to take a short break from webinars for until after Eid for some time. Inshallah, we will resume again, and hopefully this fruitful interactive sessions continues, and we get more young and dynamic speakers like you, Rameez. But thank you, the both of you, and hope inshallah, hopefully you have a lovely Eid with your family and stay safe, and as mentioned, avoid shopping for Eid. Have a lovely evening, and take care. Assalamu alaikum.
Thank you, sir. Alaikum salam.
I'm going to end the call. Bye.